Synovitis clinic, which many of us now operate so that we can see these patients early, or to someone in community care with a special interest or a nurse specialist. So note the rapid referral to areas of expertise. Triage and diagnosis, of course, is what I've been talking about up till now, and the difficulties. But once a diagnosis is established, the PSR strongly recommends specialist treatment. And I think that with modern day management of rheumatoid arthritis, if you don't get specialist input, you're doing a disservice to patients. It requires sophistication, it requires knowledge, not only in establishing the diagnosis, but in day-to-day, week-to-week, month-to-month management of these patients, and continuity of care. Patients who move between practitioners are doing themselves a disservice too. And the approach needs to be aggressive. And disease-modifying drugs from day one. Once the diagnosis is made, you get cracking. And the linchpin, the key disease-modifying drug is methotrexate. Whether you use combinations or not, methotrexate is the most important, the cheapest of the disease-modifying drugs, the safest of the disease-modifying drugs. It can be supplemented with corticosteroids, either intramuscular or into the joints, and in the early months of treatment, this is a great approach. Painkillers, and I include non-steroidal anti-inflammatory drugs in that category. They are mainly analgesics. They don't do anything else. They do not alter the course of this disease. Non-steroidal anti-inflammatory drugs have been oversold for years, decades. They're just aspirin. Self-help, important. Very demoralizing disease. Organizations exist. Physical treatment doesn't really have a big role to play, but the support of professions like physios and occupational therapists and knowledgeable support workers of other cultures can help patients with this disease. In my own setting, a nurse who can counsel patients with early disease can have a tremendous impact on the morale of patients. They need to know that they're not alone, that there's lots of support available, but there are treatments which actually work and can deflect this disease. So education too is part of that. What we do not want to see, and see less and less, is this sort of patient. I no longer tolerate patients coming to my clinics in wheelchairs. There is no need for it. This old picture of a patient with large synovial effusion of the elbow, deformed fingers, sitting in a wheelchair, we do not see it now. The management has got better and better, and the secret is what I've already referred to, aggressive early treatment with conventional disease-modifying drugs. This sort of thing. Before I came to this country 18 years ago, I was actually running a trial of managing rheumatoid leg ulcers. They were already becoming uncommon, and therefore the trial was running into trouble because we had recruitment problems. But we never see it now because of better management. And I'm going to end this presentation by referring ever so briefly to what it used to be like in the 1980s. So I'm referring to a study that I published some years ago of almost 300 patients who were followed over 10 years. They were all on disease-modifying drugs, but not methotrexate largely. Methotrexate wasn't in use at this time. So they entered the study in 1986 and it finished in 1996. And this is an important slide because what it shows is in this population how many died. Early death remains a threat to patients with rheumatoid arthritis. And we think that we can alter this trend by aggressive treatment. And in this study of 300 patients, you can see what happened over 10 years. Their life expectancy was reduced. Those are the sorts of treatments that were available. Note that methotrexate wasn't commonly used at the beginning of the study, although toward the end of the study was the most popular. Monotherapy. Well, things have marched on hugely since that study was conducted. I made early reference to combination treatment. Many believe this is the way forward. The evidence base is a little shaky. And there's no doubt that the combinations that include corticosteroids, either in small regular doses or at least in the initiation of treatment, are those which seem to have worked best. But the key is reflected in this particular study, which looked at intensive therapy. And that is the way forward. So in this particular study, the treatments weren't defined, but the philosophy was, and an attempt was made to make sure that patients, when reviewed on a monthly basis, had either sustained remission or what we call the arthritis ACR response rate that was high, 71%. And the patients who were followed routinely did much, much poorer. They were seen every 3 months compared with monthly. And there's no doubt that regular attention to patients' treatment, trying to get the CRP-ESR down to a normal level, trying to push them into remission, is the way to manage this disease. So the treatment itself is important, of course, but it has to be tailor-made to the patient, and that's the message of this particular study. Combinations, maybe, step up, step down. All combinations, as I say, should have methotrexate, with or without corticosteroids, intra-articular, intramuscular steroids. So there are a number of different fashions and a number of different approaches, but they should suit the individual. Now, my talk was going to evolve and talk a little bit about corticosteroids and the side effects, and I'm going to make some mention of biological treatments, but I'm conscious of the fact that this is, I've only got 20 minutes and I've already run over time, and some of the subsequent speakers are going to be touching on this. I don't need to develop this theme any further. I think I've conveyed my main message.